Hello, everybody. Welcome back to the Incubator podcast. We are back today for a special episode of the Incubator, and Daphna is in the studio with us. Daphna, good morning. How are you?
I'm doing really well. I was telling you offline, and this is kind of a personal area of interest and professional passion for me. So I'm really excited about the topic we have on today and for our special collaboration with Nan.
Absolutely. I'll talk about the collaboration in just a second. I'm going to introduce our guest. I'm going to start with Kathy Dudding. Kathy, good morning, and thank you for being on the show
Morning.
with us.
Thank you. Thank you for the
Um,
invitation.
you are an assistant professor at the University of Alabama and a neonatal nurse scientist for now over 20 years, and you have dedicated your career to improving how nurses understand and respond to neonatal pain. You use technology and informatics in your research to enhance communication between babies and caregivers, leading to faster and more effective pain relief. We're going to be very excited to talk to you about that today. You are joined today by Marliese Nist. Marliese, welcome to the program.
Thank you so much for the invitation.
Marliese, you're an assistant professor and neonatal nurse scientist at the Ohio State University College of Nursing. We're not allowed to miss the we were told.
Right, right.
And your and your research focuses on improving the neurodevelopment of preterm infants by reducing harmful effects of stress in the NICU. You have a background in biology, a decade of NICU nursing experience, and you combine lab science and clinical research to develop intervention that support better long-term outcomes for fragile newborns. Um, we want to mention that this episode is also brought to you today in partnership with the National Association of Neonatal Nurses, or NANN, for those of you who are familiar with the organization. NANN has, for over 30 years, led the way in supporting and empowering neonatal nurses who care for our tiniest and most vulnerable patients. Through education, advocacy, and a strong professional community, NANN is dedicated to advancing neonatal care and improving outcomes for babies and families everywhere. And as part of this collaboration, where we want to feature also NANNcast, which is the official podcast of NANN, and it's hosted by Jill Beck. NANNcast brings expert insights, latest research, and real stories from the world of neonatal nursing. And whether you are a healthcare professional or a family member with any form of NICU connection, there's something for everyone to learn and share. Be sure to check out NANNcast wherever you get your podcast and join us in celebrating the incredible work of neonatal nurses and the families they serve. Daphne, take it away.
Thank you for that. And, we really, I think for us, I mean, this is why we're so excited about this collaboration. For us to get anything done in the NICU, for us to give the best care for babies, it really has to be this multidisciplinary collaboration. I think you guys are the perfect people to have on. We're going to talk about neonatal pain and stress today. And I love this topic. Ben hates it when I say I love this topic because the topics are not always positive, but I think something positive will come of us talking about this. And I really feel in my heart of hearts that this is everybody's responsibility, not just the bedside nurse. But hopefully, you will empower all of our listeners about why it's everybody's job. I was hoping to maybe set the stage a little bit and maybe, I mean, we can take turns, but maybe Kathy, you can start with this question. Um, Tell us a little bit about the history of neonatal pain in the NICU, because I'm not sure everybody recognizes that it wasn't that long ago in our history that we actually thought babies, especially the preterm babies, may not even feel pain or stress. So we've come a long way. Even though we have a long way to go, we've come a long way. So tell us a little bit about that.
Yeah, no, thank you. That's a great question and a place to start. So just like you said, neonatal pain was only recognized in 1985, 87, so about 38 years ago. I mean, that's younger than I am. And so, I mean, to me, that's profound and just like, really? Uh, Disbelieving in that fact, and in fact, so that 19 late 98 not late 1980s, when we didn't really acknowledge that, we had our sentinel work that was done by Annette et al., and did this great study where they did finally prove that neonates do in fact experience pain, and some of the reasons why they thought neonates didn't experience pain was they're neurologically immature. So they thought, yeah, the pain receptors aren't formed. They're not having any kind of pain. Um, they have no consciousness of pain. They also thought that if they were to give them pain medications, that they simply would not be able to handle it. And we know for a fact that that simply wasn't true. And in fact, in my dissertation work, I did some interviews with neonatal nurses and specifically asking about, some of the nurses that were well seasoned and experienced and were working in the 1980s as bedside nurses, and they were just saying, "Well, of course they're in pain," but, it was that belief and the education at the time that they weren't having pain, and bedside nurses are saying, "No, they're having pain." And, it was really interesting to hear their perspective that, they're saying they have pain, and then we have others that are saying, "No, they're not," and perhaps those are the ones that are making decisions on whether we give pain medications or not. And it was very, humbling to hear these stories, but I'm getting a little off track. But once we acknowledged in the late 1980s about neonatal pain, this was a huge, explosion of, "Okay, we need to change textbooks from medicine to nursing that, yes, these neonates do have pain, and what are we gonna do with this and how we're gonna manage it?" And that has really evolved over time from the non-pharmacological means that we have, developmental care, neuroprotective touch as a non-pharm agent to really address, pain in the neonate, and then from the pharmacological perspective. And that has come a long way, and then ultimately, the pharmacological really took a hit with the whole drug crisis that we're seeing and the overdosing and the NOWS babies, the NAS babies, and really, well, maybe we shouldn't be giving them medications because then we're gonna get these babies addicted. So it's come full circle. I still feel like there's a lot of work to do, and then that's compounded on the fact that they don't show pain like you and I do. It's so subtle, and if we're not trained in those subtleties of how they express their pain, it's really gonna be hard. So
Yeah, that's great. Thank you for that recap. Um, and along those lines, we have this habit of saying, neonatal pain and stress as if they are always going together. And I think people don't understand that sometimes in these neurologically immature babies, stress is experienced as almost a painful experience, and that even if we're doing a really good job trying really hard not to do the really painful things to babies, even our day-to-day interactions with them can be stressful. And Marliese, maybe you can take this one. I know you've done, a lot of work in how does even our routine care impact baby stress.
Right. Yes, I'm very focused on the routine things that nurses do because they're arguably the most frequent. Babies get their diapers changed every 3 or 4 hours. They get fed every 3 or 4 hours. And those things are actually quite stressful for a neurological system that isn't equipped to handle it. And of course, the painful things are probably stressful, but not all stressful things are necessarily painful. And I think we forget that. And part of the difficulty is defining stress. Kathy and I met the other day to talk about a project that we want to work on collaboratively, and we were trying to come up with definitions of pain and stress. And for the two of us who have dedicated our professional lives to studying these things, we had differences of opinion on how do you define these things. So naturally, it's going to be difficult for nurses at the bedside to define those things as well. Um, but I think part of the problem with identifying and managing infant stress is the perception that they won't remember. And that really gets under my skin because, of course, they're not going to remember it in their brains the way that we remember things that have happened in our lives, but their bodies remember. And what that means is we're finding that babies who experience repeated, frequent, prolonged stress or activation of the physiologic stress response systems have changes in the way those response systems function moving forward. So the thresholds and the parameters of those systems are changed forever. And it can affect how infants respond to stressful experiences throughout the life course. So while they don't remember in their brains and they're not going to be able to tell you what that experience was like, you can see in the way that they function moving forward that their bodies remember.
That is so interesting. I think that there's an interesting paradigm shift in terms of medical care and how pain is approached in the NICU versus anywhere else in the hospital. Because I think that as physicians, we have to contend with patients advocating for themselves. Usually, when it comes to pain, whether it's in the form of "ow" or somebody saying, "I want to be premedicated before you do that thing." But obviously, as you guys mentioned, babies present a very unique challenge in which it is on us as providers to anticipate the pain level that might be generated from what we are imposing on them to then address that pain adequately. And so I think that based on what you've told us, that we have such a great understanding that it is not a myth. I think that basically, I mean, that's my takeaway from your cursory review of the history, is that we thought it was a myth that babies experience pain, especially preterm infants, and we clearly understand that today that no, it is not. They do experience pain. I am just wondering, what does that mean today? Now that we know this, um, how are the best centers um, addressing pain on a consistent way? Because I think that for many of our listeners, and I'm putting myself in those shoes as well, we may have an approach for pain in a specific scenario. And we say, oh, for these babies that come back from the OR, we have this regimen that we have in place. But I have rarely seen pain being addressed on a continuum, saying this is our philosophy in our unit when it comes to pain, and this is how we approach this. Because the 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 shortcut is to think medications, but pain is not only necessarily addressed with medication. And so I'm just curious about, with your expertise, um, how does a proper comprehensive guideline when it comes to neonatal pain, what does that look like in the modern NICU? And I'm going to give you both the opportunity to chime in on this one. So, Kathy, if you want to go first, go right ahead.
Sure. Sure. So, you know, we go back to the American Academy of Pediatrics, and from 2017, they have this great article and how we can address pain in the NICU. And one of the main points was, education, have a pain protocol, um, uh, always doing non-pharmacological measures first before pharmacological measures. We need further tool development. We need psychometric sound psychometrics with our pain scales, and we need further research with this. Unfortunately, in my career, been seeing a lot of inconsistencies with observing those types of guidelines, which is unfortunate. Um, and just from talking to nurses and nurse practitioners at conferences and such, I've always asked them, does your hospital, does it have a pain policy? And it's really inconsistent. I had one person that talked to where they said, "Oh, at this hospital I worked at, we did not have a pain protocol. We didn't give meds for anything. We didn't even give sucrose at all." And then she said, "But then I went to hospital Y, and we had this huge pain protocol, and it was almost the pendulum was too much, and the babies were just flat out sedated." And I'm like, "Oh, wow." So, I mean, while we have these guidelines, there is no standard, which is interesting. And, this standard, which we should be doing, really encompasses an interdisciplinary team, from medicine to nurse practitioners to nurses to OT to RT. I mean, that encompasses everyone. And uh, it's a little disheartening to hear that we're not consistently coming together to um, have the best outcomes for our babies here.
Marliese, any thoughts?
Yeah, I agree with Kathy a lot. I think that there are some things that we can create policies around. So, an infant coming back from the OR, we can probably create protocols for certain things. There are a lot of things that we do that are so individualized, and infants will have such unique responses that it's difficult to proactively develop a policy. For example, around a heel stick. How does every infant doesn't experience a heel stick the same way. It depends on the context of that heel stick, the infant's prior experiences, how the heel stick is done. I've seen a lot of variation in nursing care. So I think that it takes a lot of thinking about what I need to, as a nurse, what do I need to do at the bedside at this moment with this infant? Are there things that I can eliminate, stressful procedures that I can eliminate without affecting the infant's well being or long term outcomes? If the diaper's dry, there's no need to change the diaper. Um, if the infant's sleeping, can I wait a little while till this baby naturally wakes up and then interact with him in a nursing care? So there are things that we can think about as nurses at the bedside before we provide our routine care. But then also using those very subtle signs, and not every baby will exhibit them, but noticing those very subtle signs of when a baby is stressed and involving the parents, because those parents are there, hopefully and often, um, all the time, and they know their baby. So listening to those parents can be really important in understanding what the baby's experience is, because they're the best proxy. Often, I think it's great when there's consistency of care among nurses and physicians, because then they get to know individual babies as well, and they can provide the best stress management. But I think that we need to incorporate things in our routine care that are often missed. These infants are babies first and they're patients second. And we forget to provide them with the things that infants need. Infants are naturally comforted by nurturing touch, and our infants rarely get that. I did a study a few years ago and we found that I think less than 2% of the touch provided during routine nursing care was done exclusively for comfort. That is not a natural experience for an infant. And we found that by providing 1 minute of intentional, comforting, exclusive, exclusive comforting touch at the beginning of a care decreased the infant's stress responses to that care. So just being really intentional in how we approach the care that we provide.
And so I think that you guys are giving us so many interesting concepts. I think that what I'm writing down in my notebook right now is that number one, um, it's not like people have it's not that there is it doesn't seem to be a gold standard that people can just emulate right now. Basically, there's an opportunity to innovate and define a pain philosophy, a pain protocol for each unit that makes sense based on your unit's needs and resources. I heard from you, Kathy, that we have it has to be multidisciplinary. This is seems to be the key. And Marliese, I think that you're talking about we have to do better at recognizing pain and not just understanding that some of the things that we do cause pain, but have some mechanism that we can objectively assess the pain of our patients. And I really enjoy the point about touching and non painful touch. I think that this is such a great opportunity for, like you said, families who are at the bedside who really want to do something. And it's true, nurses, doctors were stretched so thin, staffing and whatever. Then maybe that could be the full time job of the family members in addition to the providers, and maximize those over painful touches. Going back on identification, it seems that there are so many scales to assess pain, and it can be so daunting to even try to decipher through them. Is are there certain scales in assessing pain that you think are better validation or more practical that you would recommend? Marlies, I'm gonna let you start on that one. Is there any tips you could give to our listeners when it comes to that?
Well, I'll let Kathy talk about the pain scale. She knows that far better than I do. As far as stress, there really aren't any. And in research, people typically use checklists of invasive or skin breaking procedures. We did a study a while ago looking at the neonatal infant stressor scale, which is a checklist of many, many different procedures that occur in the NICU. And we found it was highly correlated with skin breaking and invasive procedures. So I don't know that there's one that's better than the others. Um, However, it's a checklist. And again, as I said, it doesn't account for the context and the infant's prior experiences and the gestational age and genetic proclivities that an infant might have to stress responses. So there isn't really a good measure of stress, and it's going to be very individualized for each infant. And I think this is where clinical providers, nurses, and physicians can help the researchers. What are you seeing at the bedside that hasn't been reported before? What do we need to look for so that we can develop these measures, because they don't exist, at least for stress?
So I will add pain scales. Oh, the vein of my existence. We do the best we can.
The
Um,
pain scales are causing you pain? Is that what you're saying?
oh, they are causing me pain. So there are over 40 pain scales, neonatal pain scales out there worldwide. Um, the lack of the lack of psychometric properties with validity and reliability in these pain scales is questionable. There is no standard to which we take these pain scales and test them and say, "Oh, okay, yeah, this has good reliability and validity." And what I discovered in my research is what they do is they have one pain scale that says, "Okay, yeah, we're valid and reliable." And so a new emerging pain scale comes along and says, "Okay, well, I'll test my pain scale against this other one. And if I come up with the same value, then we must be valid and reliable too." So I would say for any hospital NICU that is looking to look at a new pain scale, one, you have to look at your gestational age. If you look at the literature, every pain scale has a gestational age on what it is supposedly valid and reliable at. You also have to look at the type of pain. Post-surgical pain is very different than, say, like procedural pain or an acute pain, such as like a heel stick. So you really have to somewhat individualize to the gestational age and what type of pain you're doing on this neonate. Um, and we also have to remember too that everything that we do on these babies, and we know unfortunately pain and stress is part of the routine care in these neonates. I just looked up the findings on this the other day because I always the literature is always changing, but on average, neonates are having 7 to 17 pain events in a NICU every single day. Now just think what we're doing to those immature neurological systems. We know we're rewiring them,
That's close to
due
that
to this
that's almost pretty
stress.
much almost 1 an hour.
Yeah, yeah,
Wow,
yeah,
every hour.
and, I mean, first of all, these neonates shouldn't even be in the NICU at this point in time. We should be in that protective womb, and everything that we do, just like Marliese was saying, should be intentional. This is a baby that we are doing everything for the first time, and those first experiences are going to be invaluable of how it informs, just like Marliese said, the body. They might not remember it, but the body will remember it, and over time, and you guys have seen it too, where you go and see assess a baby at, a baby that's been there for 2 weeks and how it responds to your touch, the jerking away, the stressing, the increase in the hemodynamic measures. We all see that. And so we have to be so intentional, and it is so hard to kind of like we learn we need to be intentional with our touch. We need to be intentional with the care that we give. But then just as you said, we are task oriented. We have to get in there. We're spread thin. We have to get in, do what we need to do, and move on to the next one. So I don't know what the answer is. I mean, it doesn't really support, even though it should, it doesn't really support increased nurse to patient ratios. But if we, because we don't see these babies long term, they're there with us for a short period of time and then they go on their merry way. And we don't know what the long term sequela is as a result of that NICU experience.
Yeah, I like to tell my team, like, when you come to the bedside, pretend that this is a baby, like, in your home, in its crib. Like, what would you do for that baby if you had to do this procedure? And, we've become desensitized, I think, to seeing these spa people who maybe don't put up as much a fight as we expect. They're not so loud. They're not so aggressive, because they're small and they're sick. But just like, I think it's a reframing and saying, like, I would not do this to a toddler in this way. I would not do this to an adult in this way. And I would not do it to a newborn in the nursery this way. And it just seems so obvious. I think the parents really get that. We the way we approach their infant and they're grimacing. And then I think that can help us realign ourselves with the babies and the families. But I wanted to touch on a point that both of you have spoken about, but I'll have Marliese address this one. I love this concept about individualization. So, of course, we want a pain scale where we can just give the baby a number and then decide what the baby gets. But of course, that's not the real world. And so I think what it comes back to, and you alluded a little bit to this, is recognizing infant behavioral cues. And I recognize that most neonatal professionals still don't have any training in recognizing infant behavioral cues. And I think this is somebody who's listening could go back to their unit and start like changing the way they see things like immediately. So if you could just talk to us a little bit about those cues, like what should people be looking for? What are the signs that we've course corrected? So we identified a behavioral cue. This baby is stressed. I did a containment hold or something. What are the signs then that the baby's ready for us to move on? Something that people can start working with right away.
That's a great question, and it's a really hard one to answer, actually. There are the obvious things. When a baby's heart rate goes from 130 to 50, the baby's not handling something well. We can all recognize a Brady or a DSAT pretty quickly.
We recognize but often ignore, right?
True, true. We say, "Oh, they'll get through this." You're right, right,
This baby desats the whole
right.
time.
You're
Yeah, let's go
you're
faster.
absolutely right. You're
He's
absolutely right.
coming
And
up. He's coming up.
yeah,
He's coming up. It's fine. Look away. Yeah,
yes, I
that's
think you're absolutely right. But so we want to prevent that extreme reaction. They're very subtle things. I think we learn when as new nurses, we learn to look for the salute and the stop sign and the splayed fingers, the arching, the grimace. We look for those kinds of things. Things that are much more subtle can be very difficult. So even a 10 beat per minute change in heart rate doesn't necessarily mean there's a problem. There's stimulation there. So just the stimulation will increase the heart rate. But really monitoring that heart rate and that respiratory rate and the very, very subtle facial signs that a baby will display. How many of us provide care and the monitor is behind us? I can't look at the baby and the monitor at the same time. So maybe we need to change our workflows or the way that our NICUs are designed so that we can take all of this information in and integrate all of these data points that we have to make an assessment about a baby. As I said earlier, getting to know our patients, if we have consistency of care, asking the parents, what does your baby do when he or she is stressed? How does your baby typically respond to this? And have you seen times when the baby's responded well or not well? Can you tell me about that? So I think having a conversation with parents before you start a procedure or a care is really helpful. Not only does it provide insight for us to be able to provide the best possible care, but it empowers the parents. And it tells them that they have a role in this and that they're not just bystanders who are there to take up space. They're really important. They're really important members of the care team. Um, so again, it's going to be very, very subtle. What I caution people about is the absence of signs and behavioral signals does not mean the absence of stress. I observed one time an infant having an arterial stick, and for me, that's a terrifying thing. I hope I never have to experience that. And the nurse came back and said, the baby did great, didn't even move.
didn't even move.
That's
Yeah,
terrifying. They
that's
should
right.
move because stress responses are protective. If we touch a hot stove and we don't move our hand, that's a problem. We're supposed to have a response to that. It protects our bodies. So, not all stress responses are bad. It's when they are repeated, frequent, overwhelming, prolonged, and they're not accompanied with some sort of help to cope. So a baby can experience a stressful event. And as you said, if we provide some hand containment, some exclusive comforting touch, if we provide a rest period, we help them to regulate and start that care with something that they'll enjoy so that not every time the porthole is opened, it's a painful, scary, stressful experience. It can just be a comforting thing. Maybe the baby's gavage feed has started and mom or dad come over to just provide hand containment. What a great thing that baby is learning. The baby is learning my stomach's filling, I'm feeling satiated, and I'm getting this wonderful nurturing touch. And my colleague and good friend, Rita Pickler, has done a lot of work on that patterned experience and why it's so important, particularly around feeding.
I love that. And I want to carry forward what you're saying. We talked a little bit about this neuronal connectivity, and I think the medical professionals can really buy into that, right? I think we forget that, like, not only is this a patient that's critically ill, but this is a patient whose brain is like literally growing and developing and making all of the majority of its connections, even in the few weeks to months that they're with us. And so they either will make neural connections that the world is scary and hard and painful, or, you know, and I think people are learning, people are getting there. They're understanding. Let's try some containment. Let's do swaddled bathing, swaddled labs, maybe vaccines during kangaroo care. I think people are buying into that. But I think there's still a leap the community needs to make in saying, well, what if babies in the NICU wired their brains that the world is a place for like bonding and love and attachment. And so I loved your mention about positive touch, and some of the things that we can do at the bedside. I also think people say, okay, well, yeah, parent involvement. Yes, the parents are there to bond with their baby, but parents may come once a day, maybe come twice a day, and we interact with the baby maybe 8 times a day, 10 times a day. And so I love this concept of bedside professionals as a part of like the caregiving team, um, more like a family member, not to replace the parent, but to sub in. And I think we're missing this opportunity to say like, the baby's not bonding with me, but it's learning about attachment and bonding by the way I recognize its cues. I give it positive feedback. I talk to it when I'm coming in to see it. I do those positive touches. So where are we with that? What is something, what are some of the things people can take home again today and start doing the very next time they go to a bedside?
Well, I mean, I love what you're saying, that family-centered care, which I know a lot of NICUs across the country have adopted. And I really think whether physicians, nurses, to really pull in to play with these parents that they are part of the team to care for this baby, and that might look different for individual parents. Again, we have to treat them individually too. We do have some parents that can be there all the time, but then we have others that are working or can only come once a day or a couple times a week, and we are that extension of that family to give that those first and that wiring of that brain, because in NICUs, we are in the business of growing brains. That's what we do, and, we just need to make it a positive experience, but I would say that, parents are part of this, and they need to be a part of this. They are part of absolutely decision making, and there are so many things that they can do if they can't be there. We have moms that can provide breast milk. I mean, what is more loving and caring than a mom being able to produce, breast milk for that baby to feed it, when they're not there? Um, and then in the sense too with nurses, we all know it with a lot of times what the social situation is with the parents, and so you can give that infant, if you have time to give a little extra care, a little extra attention, a little extra cuddling when you're holding them during that gavage feeding, talking to them. Um, we we need to make that time to be able to do that with them, and, sometimes it's not as much time as we'd like to give, but it's certainly I've never met a neonatal nurse that didn't wanna spend more time with a baby, when they were providing care to it.
Yeah, and it seems that beyond just the amount of time that we can actually allocate, it's about reshaping every interaction and trying to to have this metamorphosis of our interactions, whether it is for us clinicians, nurses, providers, and parents, and just say, all right, how do we turn this experience into the least painful experience possible? How do we maximize comfort to the extreme? And try to just adopt this consistently throughout a team. I think you guys have given us such great insight into the opportunities, in my opinion, that this particular topic presents, not just in the challenges in measurement, basically that there are opportunities to create more consistency from that standpoint. I think that the intervention about comfort touch and nursing and policies and parental involvement and intentional care. But as people are getting excited in the car, like, all right, this is it. I'm gonna take this on. This is gonna be my battle cry, and I'm going to try to devote my time to quality initiatives around improving neonatal pain in my unit. What can be your words of wisdom to them in terms of the systemic barriers that they can anticipate, and maybe what are some of the opportunities to circumvent those barriers and be as efficient as possible. So whichever one of you wants to take this first, please go right ahead.
Ooh, this is going to get challenging. So I think we need a paradigm shift in the way that we approach care for infants, and it's gonna be a system wide change. I think that unfortunately, I can speak to nursing, I can't speak to medicine. We have a list of tasks that we feel like we must complete. We must complete A, B, C, D before we can leave for the day. And we have to complete audit 1, 2, and 3. So I think we need to take a look at, and there are some people doing really great work on this, what are high value things that we do and what are low value things that we do? What can be eliminated and where do we need to focus our attention? We only have so many hours. We only have so many healthcare providers and nurses. So how do we maximize efficiency, providing high quality care, and get rid of the things that really don't matter for outcomes? That takes a lot of research. That's going to take a lot of buy-in from administration, management, nursing, medicine, and all the disciplines. But I think
Can I just plug in a Harvard Business Review article that called exactly what you're speaking of and called it the gross system, GROSS, get rid of the stupid stuff.
love it, love it,
And I just
love
love
it.
it. And I just love it. I think
Because if it doesn't
it's a
improve
great
outcomes,
analogy.
why are we doing it? Why are we doing it?
Yeah.
So I think that paradigm shift is critical. Now, smaller things we can do. We've been talking the whole past half hour about intentional care. I would love it if nurses would approach their shift looking at all of the things that they have to do and how can we either get rid of some of those low value things. Are all of those things really necessary? Do they have to be done exactly every 3 hours? So having a little bit of flexibility, as we've talked about, incorporating the parents. So really having a plan for the day, but being flexible based on what the baby tells you.
Kathy, any thoughts?
Oh, yes. So this is definitely going to be a systematic wide uh, shift. And not only that, but we have to have the interdisciplinary team, including parents, coming together with open minds, open hearts about what is best for baby when we're trying to minimize pain and stress in these neonates. The first thing I think of is magnet status in hospitals. We know that research is a major component, a part of that. And I've been part of hospitals where we had an evidence-based council. It was nurses. And weirdly enough, we didn't include the physician. And I don't know why now, looking retrospectively back on that. And when we come and discuss this, we have to have the most update literature. I've noticed that a lot of bedside nurses do not have access to library literature. Why? They absolutely should. If you want to make change on your unit or make recommendations for change to an interdisciplinary team, you've got to have the most current literature at your fingertips. So I think that is something that could be worked on. That would be small potatoes. To have that continuing educations, that's what nurses should be doing anyways. We are lifelong learners. And I really think it comes down to it's just everyone being open and being respectful of others' opinions, what we're finding. If you come to a stakeholder and they say no, be able to be comfortable and say, well, can you explain why and provide the rationale. I think if we could approach it with that mutual respect of all parties, I think we could really move mountains and really change outcomes for these babies.
And I think Kathy made a great point. I think as researchers, we need to do a better job. As
Mhm.
an undergraduate and then as a second degree nursing student, I'd be told to read a paper, skip the message, don't understand, don't know, but what's the discussion? So I think that we need to do a better job of producing the white papers for the clinical providers so that they know what we're finding in our research and how it can be implemented directly into their practice. And our professional organizations could be great advocates in helping make that happen. I'm working with NANN now to see how we can better communicate between the clinicians and the researchers so that the researchers know what to ask and the clinicians know how to implement it. So I think that there's some great opportunities there.
Oh, I completely agree, but I do think we do need to incorporate that interdisciplinary team. Everyone has to be a part of the discussion, the pros, the cons, the evidence that's there, and can we come to a compromise for everyone? Why can't we be that way? I mean, why can't we all just get along in that way?
I think that
I mean
you guys are bringing up such interesting points because I think that I think that the discussion, the breakdown of discussion within the hospital system has always been that we all have different incentives and are we aligned? Are we all aligned? Nurses, doctors, administration, and so on and so forth. But somehow it seems that our incentives are pretty much well aligned when it comes to this particular topic. I think that administrators, it's a slam dunk if you're able to advertise that your hospital has a comprehensive plan to address neonatal pain in the NICU. It will beg the question: are the other units doing it? Are these other guys doing it? It makes you stand out. I think that nurses and doctors, while being stretched thin, do have this priority of baby should come first, and neonatal pain is something that I have a hard time believing people would shrug it off and be like, that's not important, especially in this day and age. So so it's interesting that maybe if communication was a little bit more streamlined, we might actually get there by just exactly as you guys said. Just this is it's all about the baby and their experience. I mean, come on.
Mhm. Well, it's really interesting too because, just like from a researcher point of view, and you all will understand, we will fund someone who has cancer, high blood pressure, find a cure, let's figure this out. But then you look at the babies who are having pain and stress and trying to alleviate that, and there's not that connection that this experience that they're having lasts a lifespan. This isn't just for, oh, when they're in the NICU. However long that poor person lives, they might be ultimately affected from their care that they received in the NICU,
Yes.
and we really need to do a better job as researchers, as nurses, as physicians, and other stakeholders involved to improve the outcomes for these babies.
Yeah.
Yeah. I know we're getting near the end of our time, and I hope for some people this was preaching to the choir, and I hope for others this was saying like, "Oh, I really learned something new. I want to learn a little bit more about it." And I'm hoping that you each will recommend some resources. I'm going to recommend one of my favorites that comes from a multidisciplinary committee through the Gravens Conference, which I think if people are just wanting to get their feet wet, that's a great place to do it. It's held in Clearwater, Florida, uh, at least in the last few years. And they actually have put their recommendations together, the infant and family developmental care standards. So again, not just family developmental care, but infant developmental care. So focusing on the infant themselves, and that can be found at NICUdesign.nd.edu. And I think it's a really easy resource because it's split up in all these easy to understand sections. The topics are simple and really comprehensive. So, but I'd love to hear your favorites.
There's a great book that is endorsed by NANN on developmental care of the NICU infant. That's a good resource. It's lengthy, but it could be helpful. I'll have to think about what some of my other favorites are. There are some great reviews out there on infant stress and pain. If you don't have the time to read all the primary literature, of course.
Um, I I have to say there is a great, book, it's called The Handbook of Neonatal Pain. You can buy it on Amazon, and it's widely available, and then, what else? There was an article published on the fetal paradox on fetal pain that was mind-blowing from, what the fetus is at the developmental stage, and these were fetuses that were receiving surgery in utero and the whole pain issue, uh, mind-blowing. I haven't been the same since, but, it's really informative about how that neurological system forms and then how those pain sensors start out as, like, being really big, and then they get smaller as they mature, and what these how they were handling pain in these fetuses that were undergoing surgery while in utero. So that was a really interesting read. Um, but those are the two ones that I have found to be helpful.
Thinking more broadly, and it's not going to provide practical advice for what you can do, but from more of a philosophical perspective, Sean Koff is a pediatrician, and he has significantly influenced the way I think about things. He's a pediatrician who talks about the effects of early life toxic stress on long-term health outcomes, and it applies so wonderfully to our NICU patients because you could say that this is a toxic environment, a toxically stressful environment, and therefore has effects on long-term infant outcomes. So I highly recommend looking at his work. It provides a really good foundation for the way that I approach my research. And I think the way that we should all approach the care for these infants is that everything we're doing is affecting how their brains are connecting and how they develop long term.
It's the most exciting aspect of our work and the most terrifying one at the same time. That every little interaction that we have in the NICU has likely some long-term impact. It's such a double-edged sword that it can be so exciting and so scary at the same time. Kathy, Marliese, thank you so much for joining us today and for this great conversation. I would like Marliese to just give a plug to an upcoming article that we'll be looking out for in the seminars of perinatology. Am I correct?
Yes, we're hoping that we were invited to provide a paper on NICU stress, and that should be submitted pretty soon. We talk about
Yeah.
the developmental context for those stressors and some of the significant stressors that we can all have an effect on.
Yeah, and mitigating exposure and so on. So we'll be looking out for that, and maybe an opportunity for us, definitely, as we were talking about having access to the latest evidence. So maybe an article that we'll look forward to review on our upcoming episode of Journal Club.
Oh,
Um,
could I say one other thing? Marliese and I, in the past year, were co-editors for Advances in Neonatal Care on Stress and Pain in the neonate, and the third issue has just been released, but we have a smattering of articles on pain and stress that Marliese and I were able to be a part of, and so it was really exciting. So I,
yeah,
I would like to put that plug in too for
Yeah, thank you
Advances.
for that. We will actually link to those resources in the episode show notes so people who want to learn more can actually access these as effectively as possible. But yeah, thank you both again very much for your time and for all the work you're doing. I mean, you're really moving the needle forward on a topic that is often unaddressed, sadly enough. So thank you both very much.
Thank you.
Thank you.